I'm Kiyotake Ishikawa. I'm an assistant professor at Cardiovascular Research Institute. I work on cardiac research using pig models and try to translate new therapies that have been shown to be effective in bench and bring it to bedside. So a lot of my work involves drug delivery in human-sized animals. So I wanted to discuss current status of these drug delivery methods for the heart and the potential rooms for improvement in these approaches. So large animal studies are fundamental work for clinical translation. It's because size and physiologies are very different between small animals or the in vitro models compared to human, and new therapies needs to be tested in more human-sized animals with a similar cardiac physiology. The pigs are preferred because it has similar heart size and cardiac physiologies, including heart rate, action potential duration, and so on, are very close to humans. Here are some of the therapies that we test in these models. The drugs are developed as I speak now. Gene therapy is something that has been very hot recently, and there have been a few drugs that was approved for clinical use in the past few years. Cardiac stem cell therapy has been tested in the past 15 years, but a lot of these fail to translate to real clinical practice. So the main issues, I think, is the non-selective nature of these materials. Because it's not cardiac selective, these drugs or cells or vectors can go into off-target organs, and they can cause side effects. And because we lose a lot in non-target organs, we need much more dose for achieving therapeutic level for the heart. And that raises the cost of drug development. And also the production become difficult for massive amount. So we really need a selective and effective cardiac delivery method. Here are some of the barriers for cardiac targeting. From the top, it becomes smaller and smaller when you reach down. The first one is anatomical barrier. So the heart is inside this chest cavity and it's protected, so it's hard to target. When you try to get through the vascular route, there is blood that always try to inhibit external materials to reach the heart. Even if it reaches the heart, there's an endothelial barrier that blocks materials to get into the heart. And even if it passes this barrier, there's hurdles for cell entry and also intracellular trafficking. All of these are very important, but today we will focus on the top three, anatomical to endothelial. So the first approach to overcome, to target the heart specifically, is to use carriers. There are two approaches. One is encapsulation. It's to package the materials by lipids, polymers, microbubbles, and exosomes. Or you can bind something on the vectors or drugs to with antibodies or synthetic peptides. So the advantage is the low invasiveness, it's clear because we can just inject into the arm with a small needle stick, and it can reach the heart if the carriers are effective. But current carriers are not so selective, and a lot of them are still taken up by off-target site. There's an issue with encapsulation and binding efficiency. It's not complete. And also there are side effects related to these carriers. And even if you put materials along with these carriers, there still is endothelial barrier that blocks the drug entry to the heart. Now, because of this, we still need to try mechanical approaches to deliver these materials into the heart specifically. So from here on, I will talk about mechanical approaches. The first one is intracoronary delivery. This is to bring a catheter from the arm or the femoral puncture, small stick, to the vessels, and bring this catheter all the way to the heart and inject therapeutic materials into the coronary artery, which supplies oxygen and nutrients to the heart. So this approach is very similar to coronary catheterization that's been done in a lot of large hospitals, and all the procedures are very established, and it's relatively low invasive, and the patients with advanced heart failure can be treated using this method. So it's relatively safe and it's cardiac specific. So it's good, but there's still endothelial barrier. And if the materials cannot be taken up with the first pass, they will be distributed into the whole body. And there's a lot of off-target distribution. So even if it's selective, this is considered a low effective method compared to other more invasive approaches. Next one is epicardial direct injection. So this is a needle stick using a very small needle, and because it directly injects the drug or the vectors into the myocardium, it can have really high concentration of therapeutic material with a higher retention compared to the vascular delivery. You can also directly visualize the injection, so it's a confirmed injection. And the major benefit is that it overcomes endothelial barrier because you directly inject into the muscle. The challenges are that it requires open chest surgery, and because it's a needle injection, the distribution will be spotty and heterogeneous. Also, there's a leak from the needle puncture site, and although there's a study that tried this suturing technique on the myocardium and inject the vectors into the heart, the efficacy of this method has not been clearly demonstrated. And we also tried this, but I don't think it improved the efficacy of gene therapy so clearly. Because surgical delivery is too invasive, there's an approach, people try to inject the vectors using direct injection method from the endovascular side, endocardiac side. So the catheters with the needle are introduced into the heart from the vascular puncture, peripheral vascular puncture site. And using image modalities, the catheters are brought into the heart. And with the guidance, therapeutic materials are delivered. And because it's a direct injection method, most of the advantage and challenges of Pericardial delivery method is still there. Although it's less invasive compared to surgical delivery, it is at the cost of less firm injection because you are not directly seeing the injection. And also there are limited tools available right now. For example, here are some of the catheters that have been used in the past clinical trials. This is a helix catheter. It has a screw type needle on the tip. And by screwing this needle inside the myocardium, you can inject the materials into the myocardium. This is a Noga system. It's a very unique system. This catheter has an electrode that can detect the electrical activity of the heart of the myocardium. And when the myocardium is injured and there's only fibrous tissue, you don't see much electrical activity. So you can see where the normal tissue and injured tissues are. So the treatment for the border zone can be done using this imaging modality. It has a needle on tip, so by detecting where you want to inject, you can aim where you want to treat. Transaxis is a catheter that allows epicardial delivery. This catheter is inserted into the coronary sinus, the venous side, and there's a ultrasound in this system, and you can tell which side is the myocardium. So the needle is inserted into the myocardium using this guidance, and using this method, it's very unique that you can inject therapeutic materials from the epicardial side using catheters. But obviously, the vasculatures are not everywhere, so the injection site is limited to the catheter deliverability. And this is a needle injection catheter. It has 3 curved needles. So with one stick, you can inject 3 different sites, and it might have more secured injections compared to just one stick. It also might increase the potential possibility of vector loss. So these have been used in the past clinical trials for stem cell delivery, but it turns out that Noga system is no longer under production. And also I wasn't able to find any information for these 2 on the market. The helix catheter was still on the market, but when I contacted the company for my research, they said they're not interested in doing research, and they are now only working on clinical therapies that can be tied with this helix catheter. So currently, there's really no catheter options for new therapies to try in large animals or even for humans. And I think there's a lot of room for new technologies to replace these old technologies. The reasons I think these old technologies failed is probably because the injection is really difficult. The heart is pumping about 60 to 80 times per minute, and every contraction, it moves like a couple of centimeters. So it's like giving water to a child who is on a swing. You can probably give some, but you can imagine that most of the vectors or most of the water can end up being on his face or wherever you are not intended to deliver. So that's what I think it happens with just a simple needle. And I think helix catheter has some advantage of securing the injection site. But that catheter also has a risk because when you try to treat myocardium after acute myocardial infarction, the myocardial tissue is very fragile, and with a needle stick, it can easily perforate. So I think safe and new technologies that can improve previous method that can overcome these challenges will be a really big benefit for everyone targeting cardiac therapies. Okay, pericardial delivery is another approach that can be delivered percutaneously. From the under the sternum, we can put the needle and inject drugs or vectors into this space. It potentially prolongs the cardiac retention, but it may be subject to the rapid turnover of pericardial fluid. And also the puncture hole leak cannot be prevented unless you use an open chest surgery. There's actually not so much data on this delivery method, but one study that looked at gene therapy efficacy showed that there was only epicardial expression, and the vectors that were delivered into this pericardial cavity were not able to reach the myocardium. So it might be not so efficient. Now, I talked about low efficacy of intracoronary delivery in the slides, a few slides before. But there's a study that looked at the factors that regulate cardiac uptake for gene delivery vectors. So these studies showed that perfusion pressure, coronary flow, and vector dose, and longer time inside the heart are all important factors that increases cardiac uptake of the vectors. So researchers tried to modify these factors by using different techniques, including coronary artery occlusion, so blocking the entry, also coronary sinus, the venous side occlusion, to seal the exit. They also tried injecting the vectors into the artery side or also the venous side. So using these methods, it prolongs cardiac dwell time. And by occluding the coronary artery, it blocks the blood entry. So it reduces the inhibitory effect of blood. And also by occluding the coronary sinus, it increases the capillary pressure, which can help overcome the endothelial barrier for vascular delivery. The problem with these occlusion methods is the myocardial ischemia. So because it occludes the coronary artery, the heart can't get enough oxygen and nutrients. So it starts to become dysfunctional and the blood pressure falls, there's risk of arrhythmia, and the heart can potentially stop if you do this for too long. In our lab, we try to overcome this myocardial ischemia by placing a catheter-based left ventricular assist device called Impella. This catheter became available for clinical treatment in about 10 years ago. It has a shaft that is placed across the aortic valve. And on the proximal side, there's a rotor with a fin. So this spins really quickly, really fast. And the spin draws the blood from the distal side. So the blood flows like this, and it sucks up the blood from the distal inlet, which is placed in the heart, and pushes the blood forward to the systemic circulation. And this can be inserted from the femoral artery or also from the carotid, not carotid, but the subclavian artery by cut down. This is an actual image during our experiment in pig. So the Impella device is placed inside the heart. The blood is drawn up from the heart and injected into the ascending aorta, and it's delivered to the systemic circulation. This is a coronary angiogram. The contrast is injected into the coronary artery, and there's a catheter that's ready to block the coronary sinus, the venous side. So when we occlude the coronary artery without any support, of course, the heart becomes ischemic and the blood pressure in these pigs fall rapidly. So it becomes below 60 and we had to deflate the coronary balloon. But with Impella support, we were able to maintain the blood pressure for 5 minutes in the same animals. And 3 of them, we did longer ischemia, and they were still fine after 10 minutes. So this Impella support prolongs cardiac ischemic toleration, and we were able to deliver genes into the heart using this coronary sealing approach. And our preliminary data looks really promising, and the vector uptake is increased and gene expression was also increased up to 500-fold. So this is catheter-based. All the modalities are available in the cardiac catheter, and with a cardiac assist device in place, it improves safety during these interventions. But these catheters are still thick. Impella is 14 French right now, and this catheter was 7 French, and it requires a lot of sticks into the peripheral vessels. So I think there is still room for new devices to replace or to improve these pretty thick catheters and make it smaller, make it less invasive to further improve safety. So in summary, cardiac targeted delivery requires carriers or mechanical approaches, and both approaches need much more refinement for better efficacy and safety. There are several options for catheter-based approaches, but there's not many devices available for endocardial delivery. And also new catheters, devices, or even the carriers can be developed for effective and safe cardiac delivery. Thank you very much for listening.